All right, so let's talk about IgA nephropathy. And then I guess I've also included HSP in a conversation, a related conversation, okay? There is some relationship between HSP and IgA nephropathy. Let's make sure we define those terms. HSP, excuse me, HSP is invoked when I have vasculitis that involves other vascular beds. Okay, so HSP when I have purpura, but will look indistinguishable in large part on the kidney biopsy. Okay, so when I don't have vasculitis in, manifesting like purpura, mesenteric vasculitis that might manifest as abdominal pain and hematochezia, or arthralgias is another classic manifestation of HSP. Then I can just sort of narrow this and say, okay, this is just IgA nephropathy. But we'll talk about the relationship with HSP. Here's an introduction to that conversation. Okay, and there may be some differences in disease pathogenesis. I think I'll get into that when I talk about the HSP. Now, in terms of epidemiology, IgA nephropathy is said to be the most common primary GN worldwide. Okay, so that means lupus is the most common secondary GN. Okay, and you can just look at our Parkland clinic numbers where we have over 500 lupus nephritis patients that have gone through the Parkland GN clinic. I don't have the top of my the IgA number off the top of my head, but it'll be somewhere around 160 or something like that. So much more common lupus. But if you look at the numbers of IgA versus FSGS or membranous in our patient population at Parkland, again, you'll find that IgA is the next most common GN that we're treating there. Okay. It happens most commonly in the second and third decades of life, though it can happen at any time. Interestingly, there's a racial predilection for the East Asian population. Much of this may be from differences in biopsy practices, because in East Asia, there is a greater enthusiasm for performing kidney biopsy for patients who manifest hematuria, even if you don't have much proteinuria. Okay, many times if you have hematuria without much proteinuria, we'll say you probably have either IgA or some thin basement membrane disease. We don't have to do anything at this point, so it doesn't make sense to do a kidney biopsy. Okay, so some of this may be driven by biopsy practice. Some of that is probably real racial differences. Okay, and interestingly, Blacks are less commonly developing IgA nephropathy. That being said, we've certainly diagnosed IgA nephropathy in our Black patients at Parkland. There is a slight sort of tilt towards males more commonly than females developing IgA nephropathy. In terms of pathogenesis, there's multiple hits that must manifest in order for the full disease expression. Okay, the first hit is an abnormality in IgA. Okay, you have two types of IgA subclasses, IgA1 and IgA2. This involves IgA1. There's a hinge region in this IgA molecule that undergoes post-translational modifications where there is galactose residues that are added, sialic acid residues that are added. So these unique IgA molecules have low amounts of galactose at the hinge region of the IgA antibody. Okay. I then, as a second hit, produce an autoantibody that targets this abnormal IgA molecule. Okay, so first hit is the abnormal IgA. The second hit is the production of typically an IgG that is targeting this abnormal IgA, this abnormally glycosylated IgA molecule. Okay, and then I start to form larger immune complexes. So these tangles of IgG and abnormal IgA form these larger lattice structures, these immune complexes. They're also associated with circulating soluble receptors and become these larger immune complexes that are in circulation. And then these large immune complexes start, which are sticky, start depositing in the mesangial matrix. That would be the hit 4, okay? And even that is not sufficient for disease expression, okay? I might see all of these things even in cirrhotic patients. Cirrhotic patients, not uncommonly for any cirrhosis, whether it be alcoholic or hep C cirrhosis. If you do, there have been some autopsy studies that looked for IgA deposition in cirrhotics. And they find that you see mesangial deposition of IgA in a lot of cirrhotics who don't have much renal disease, who might have a subtle hematuria or nothing on renal parameters or non-invasive renal parameters. Okay, so that's not sufficient to express the full-blown IgA nephropathy. You have to have some abnormal response to this immune deposition of immune complex, IgA-rich immune complexes. These mesangial cells become activated and they begin to elaborate matrix, which is abnormal in both quantity and quality. And then I start developing proteinuria. Okay, so you can see there's multiple hits. Some of this is heritable. You can find increases in galactose deficient IgA molecules in relatives of IgA nephropathy, but that's not sufficient to present with disease. You need all of these subsequent events to occur such that there's not clear heritability of IgA nephropathy. Even there's heritability to the production of galactose deficient IgA, there is not heritability to full-blown expression of disease because of these subsequent multiple events that have to occur. Okay, and there's probably also a stochastic event and an unpredictable event where I have some immune activation by virtue of a mucosal invader, right? I have a bacterial infection or a viral infection of the aerodigestive tract, right? Diarrhea or a URI. That could also be another sort of randomness to the disease presentation, such that it's not just familial. Okay, there are rare familial clusters, but in general, IgA nephropathy is not deemed to be a familial disease. Okay, the clinical presentation distills down to maybe 3 categories. 45% of cases have incidental microhematuria and proteinuria. Okay, and that's usually persistent. Okay, and then 45% of patients have actually episodes of gross hematuria, and that can occur fairly rapidly when a mucosal infection occurs and is distinct from the post-infectious glomerulonephritis, like post-streptococcal GN, that typically requires 1 to 2 weeks in order for the GN to manifest. The Coca-Cola colored urine after a URI with a streptococcal infection, that's typically 2 weeks later, okay? Sometimes even longer. But in IgA nephropathy, it typically happens in sequence or at the same time as the mucosal infection or shortly thereafter. Okay, and some have used the term synpharyngetic nephritis as opposed to post-pharyngetic nephritis, the post-streptococcal GN. Okay, to make that distinction. All right. And then in less than 10% of cases, you might have the severe expressions. Nephrotic syndrome can happen with IgA nephropathy, but it's uncommon. RPGNs or even acute kidney injury from a florid obstruction of tubules by RBC casts. Okay, that can also be one disease presentation. This is what the textbook says. I will tell you that my experience is this incidental proteinuria and microscopic hematuria with varying degrees of GFR decline is significantly more common than the other presentations. Okay, that's what I see most commonly. Okay. And it's not even close, even though this is what the textbook says. There is a significant set of disease associations to be aware of. We've already gone over chronic liver disease. Celiac has a loose association such that patients, especially those that search the internet before they see you, are going to be asking you about, should I adopt a gluten-free diet? And, you can tell them that this is very weak. If you want to, it's harmless. You can try it. Seronegative arthritis is associated. What do I mean by that? That's your ankylosing spondylitis. Basically, your inflammatory arthritis without a positive rheumatoid factor, right? So ankylosing spondylitis, psoriatic arthritis, those would be considered seronegative arthritides. There's an association with inflammatory bowel disease, HIV, typically in advanced stages, not just sort of asymptomatic HIV. Sarcoidosis has an association, and there's an association with malignancies. The predictors of prognosis, trying to look ahead at a stopping point here. We'll stop at the predictors of prognosis that will inform how you treat patients. Okay, so that's similar to our previous conversations, right? You prognosticate first, and with prognosis in hand, that's when you weigh the pros and cons of starting immunosuppression, right? So you do the same with IgA nephropathy. Now, we have more models with IgA nephropathy, and there's even a calculator, the IgA prediction tool. I probably have that somewhere in here. Yeah, IgA, International IgA Nephropathy Prediction Tool. You can go online, that's free as well, and plug in certain factors of the disease presentation. Now, that prediction tool doesn't tell you you should treat. It's just going to tell you after the output of that is here's the risk of decline in GFR or ESRD in the coming years. And you still have to make a decision, a cost-benefit ratio with you and the patient at the bedside. Here's what the IgA nephropathy prediction tool predicts for your near-term future and long-term future. Do you want to start immunosuppression? This is my recommendation. Okay, it's not going to tell you you should treat a patient. You still have to do that hard work of being a doctor. Okay, proteinuria. Proteinuria is one of the main prediction factors. Can someone open that door and just make sure nobody's waiting outside? Because sometimes there is a conference that I don't want to. All right, so we'll go over a little bit then. Proteinuria is one of your main predictors. And if I get a proteinuria less than 1 gram per day, that's analogous to the subnephrotic membranous. Your work is done, okay? You don't have to come out and treat the patient with all these other toxic interventions, okay? So if you can get the proteinuria less than 1 gram per day, in general, your work is done, okay? Because all patients that have a sustained drop in GFR generally have persistent proteinuria that's greater than 1 gram per day, okay? And if you can get it less than 1 gram per day, here's your risk of ESRD at even 20-year data, it's 5%. Okay, so that would make the argument that it's probably not worth the side effects of these immunosuppressives to treat patients who have less than 1 gram per day of proteinuria. Now, on the flip side, if I have proteinuria that's greater than 1 gram per day, you can see the ESRD risks at 20 years are markedly increased. So that's why that is a profound driver of prognosis, okay? And if I can get their proteinuria from initially over 1 gram per day to less than 1 gram per day, that's equivalent to a patient who's presenting with less than 1 gram per day of proteinuria. Hypertension is another major risk factor for rates of ESRD. And here are some other rates to chew on. I won't go through them. You can see relatively low rates of ESRD if you're normotensive and relatively high rates of ESRD if your blood pressure is uncontrolled. That's why treating an IgA nephropathy involves really aggressive blood pressure control, okay? Interestingly, if I have this macroscopic hematuria, if I don't have the sustained proteinuria intervening between them, that's a favorable prognosis. Okay, the patient who develops a URI and gross hematuria is actually one that does very, very well. And again, I told you those are uncommon, even though the textbook says that's, second, or that's equally common to the microhematuria. That's not my experience at all. Renal biopsy markers of worse prognosis exist. However, these are significant. These are not superior to proteinuria and hypertension. Okay, so even though there's some false reassurance that a kidney biopsy tells you a lot, I always say, if you're doing a poll to determine where the electorate is going, you're not going to take a poll of 20 voters and say, this is what 3 million of you are doing, right? That's what you're doing functionally when you do a kidney biopsy. I'm sampling 20 gloms to say, what is the 2 to 3 million glomeruli doing, right? So there, kidney biopsy is helpful, but it's not more, it shouldn't be weighted more than your clinical predictors. And that's even been studied in IgA nephropathy. Kidney biopsy is not superior to clinical predictors or non-invasive clinical predictors in predicting prognosis in IgA nephropathy. However, there are some predictors that have some predictive value. So obviously, if I have significant interstitial fibrosis, that's going to predict more severe prognosis. And then weak predictors are the degree of endocapillary hypercellularity or mesangial proliferation. Those are actually quantified in a MEST C score. Okay, all of these attributes: how much mesangial proliferation is there, endocapillary hypercellularity, tubular atrophy. Tubular atrophy is the best part of the MEST score, which is intuitive. So putting it in a complicated score really doesn't add a whole lot of value. Interestingly, the presence of crescents is not that helpful in predicting prognosis in IgA nephropathy, okay, even though it's part of your MEST C score. Now, I made the point that this score really has limited added value to your clinical predictors, okay?